Scenario 1, a gastric ulcer with massive upper gastrointestinal bleeding. A 58-year-old female was rushed to the emergency room department following 3 bouts of hematemesis and a single bout of melena. On examination, she was tachycardic and hypotensive at 121 beats per minute and 90/50 respectively. She manifests pallor with no icteritis. She's euphenic and normothermic, but reports of intermittent periumbilical tenderness. Medication history reveals occasional intake of non-steroidal anti-inflammatory drug naproxen at 250 milligrams for arthritis management. On admission, her complete blood count revealed a hemoglobin level of 5.1, hematocrit of 32%, prolonged prothrombin time, and a positive Guaiac test. All other laboratory studies were within normal limits. Based on these clinical presentations, intravenous fluids were administered in 3 bags of packed red blood cells were transfused. A gastroenterologist was consulted and an upper gastrointestinal endoscopy was performed, in which a 1 by 1 centimeter hemorrhagic gastric ulcer. The bleeding was cauterized, the biopsies were taken, and the Helicobacter pylori, the results of which are negative. Proton pump inhibitors were started, and she was discharged after 2 days in stable condition. Scenario 2, uncontrolled, non-insulin dependent diabetes mellitus. A 50-year-old female with non-insulin dependent diabetes mellitus was seen in her primary care provider's office with reports of diminished sensation in both feet and occasional blurred vision. The client admits to problems adhering to her prescribed dietary medication regimen. She does not exercise regularly, takes her medication only when she is reminded, and doesn't watch her diet. She denied dyspnea, polyphagia, polydipsia, and polyuria, and diaphoresis. The client had a history of non-insulin dependent diabetes mellitus for 15 years, dyslipidemia and hypertension for 8 years, and she had a laser photocoagulation for retinopathy in the past year. She is on metformin and glipizide for control hyperglycemia, hydrochlorothiazide and ramipril as antihypertensives, and atorvastatin for hyperlipidemia. Upon examination, her blood pressure is 185/98. Fasting blood glucose is 265. Hemoglobin is A1C is 9%. Serum blood urea, nitrogen, and creatinine at 53 mgs and 4.4 mgs respectively. Urinalysis and 24-hour urine collection uncovered trace protein and urinary albumin excretion rate at 255 mgs a day, leading to a diagnosis of microalbuminuria. Nerve conduction studies and electromyography confirmed diabetic neuropathy, decreased visual acuity, and new extensive reticular vascular growth were revealed through her ophthalmologic exam. Based on the client's typical presentation, the final medical impression and the diagnosis is uncontrolled insulin-dependent diabetes mellitus, complicated by her hypertension, her dyslipidemia, neuropathy, retinopathy, and microalbuminuria.